Thanks to Gareth and Vicky for the invitation, and thanks to you all for being here and for listening. You've already heard a fantastic view from OHCA, from one end of where cardiologists get involved in out-of-hospital cardiac arrest. So looking at this early phase and all the great work that's being done to get cardiac arrest patients into cardiac centres faster and the impact that that has. I'm going to talk to you about the other end, so what happens after everybody's done all their good work to get a well enough patient to step down to the coronary care unit, and how do we then look after those patients. I'm going to focus really on the heart, and I'm going to focus even more than that and just talk really about causes of VT and VF cardiac arrests. My own clinical interest is in the inherited cardiac conditions, so I'm going to be really selfish and focus a little bit on that. And I'm also going to talk about sudden cardiac death and some of the work that we're doing there. So you've heard a lot about STEMI and about myocardial infarction, and that they are very, very common causes, as we all know, of VT and VF out of hospital arrest, okay? But there are some other ones, okay? They are some other acquired causes, congenital causes, and also then some inherited causes. And lots of these are rarer. Some of these spots are so small that you think, well, really, what are the chances, Rachel, that I'm ever going to see somebody has a cardiac arrest because of one of those? And some of these conditions can be rare, but the absolute risk to an individual with one of these conditions can be many, many folds higher than in the large population of patients who have acquired coronary artery disease. So it is worth a focus then on those conditions that have that individually much higher risk of cardiac arrest. So this is how I think about it, okay? So this is a really useful diagram. I'm sorry, some of it's a wee bit small, but this comes from the ESC guidelines on the prevention of sudden death. So this is like a distillation of a cardiologist's view of the causes of cardiac arrest. And I like it because you can kind of see across the life course, it's got men and women, and it talks about the different causes, and it's got some really nice little nuggets of information. So we've already said that acute coronary syndrome and chronic coronary disease are the commonest causes of VT-VF arrest. But what I'm going to say to you, if you look at the little gene icons over here, right, is that inherited causes are not actually as uncommon as maybe we think they are. So this is how I think about inherited cardiac conditions. We've got purely electrical diseases, so things like long QT syndrome or Brugada syndrome that you might have heard of. So those are things that really exist on a person's ECG, right? And then we've got structural diseases. So these are the cardiomyopathies. These are the things that affect someone's heart muscle. So their heart is going to be structurally abnormal. And one thing that ties all of those conditions together is that they all have a risk of ventricular arrhythmia, cardiac arrest, and sudden cardiac death. So coming back to our kind of summary, how do we approach this to kind of pull out what information is useful on the ground? So I sit in my clinic and see people wondering about what caused their VF arrest maybe 12 months after they had it. And one of the things that I always do is go back to what the ambulance crew wrote, right? Because they are the people that were in the room fastest, who spoke to the bystanders, to the relatives, and got the story, the cleanest version of the story, right? And the circumstances of that cardiac arrest are a massively useful clue for me when I'm trying to sift through to work out what might have caused an arrest here. You can maybe see some of these little icons. So there's cycling versus swimming. That makes a difference. So not just exertion, what type of exertion you're doing. Some of these conditions have a greater risk of cardiac arrest in sleep. So those circumstances of the arrest is really, really useful information for a cardiologist down the line. The other thing that's really, really super helpful, and I hope that some people write this on their postcard, okay? Because this is really going to help me if some people do this. So the type of arrhythmia is really, really important, okay? And I'm not asking for any fancy ECG interpretation here. This is what I'm talking about, okay? So the differentiation between monomorphic VT, so cardiologists, a lot of what we do is about making a simple thing sound fancy, right? Monomorphic VT means it all looks the same, right? Every single beat just looks exactly the same, just repetitive, okay? Versus this one, where everything looks different. That differentiation is really critical for me because I can divide these inherited syndromes, which can sometimes be difficult to diagnose. I can divide them across which ones can cause monomorphic VT and which ones don't. So if somebody puts that on their postcard, I'll be really, really delighted. I want to just say a little word about these electrical diseases. Okay, so we've talked about structural and electrical. The inherited arrhythmia syndromes, the ones that live just in the electrical activity of the heart that we see in the ECG, these are the ones that I will be thinking of when you guys tell me that a patient had polymorphic VT, it didn't all look the same, or VF as their primary arrest rhythm. And there's a couple of things that we can pull out that, again, are helpful. So this polymorphic VT very often does this sort of thing, right? Comes along in a burst, and then it sorts itself out again, okay? If you happen to have an arterial blood pressure tracing while it decides to come along, then you'll see it drop like a stone, okay? So it's very rapid hemodynamic compromise that happens with this rhythm. The other thing that is kind of important to know is that these inherited arrhythmia syndromes have this massively discontinuous clinical spectrum, okay? So if you have coronary disease, we might hope that you start getting some angina or some chest pain to give us the idea that you've got coronary disease before you have your cardiac arrest. If you have long QT syndrome, you can walk around your whole life with a terrifying QT interval on your ECG that nobody ever knows about, and you can be completely asymptomatic until your heart starts doing that, which might mean you have syncope or seizures. You don't have palpitations because you're not conscious long enough to be aware of anything of the rhythm. You just become unconscious. So you might not even see a cardiologist. You might go to a neurology clinic. So we have this challenge in identifying some of these inherited arrhythmia syndromes because they can hide from us, and we need to look for them because an asymptomatic person can turn into someone with a really dangerous rhythm. What we also know is that things that we all encounter in everyday life, diarrhea and vomiting, which drops your potassium, can actually be hugely dangerous for some of these patients with inherited conditions. The same for drugs. Some prescription drugs will prolong your QT interval, and recreational drugs, drugs of abuse, can be massively harmful in these people. Just when you thought it couldn't get any more tricky, these electrical patterns living on people's ECGs can come and go. So that's super good fun, right? So somebody can have Brugada syndrome, have a cardiac arrest, and then come to clinic with a normal ECG. Brilliant. And obviously, because we're talking about inherited conditions, and we've got this really discontinuous spectrum, then we know that actually asymptomatic or well relatives might actually be at risk, particularly if those relatives come along in contact with some of these situational triggers. So it's an unusual clinical situation, and that means we need to kind of be aware of it, be live to the possibilities, and understand how to get people down that pathway if it's correct. So this is what I teach to cardiologists. I'm not going to go through this in any detail, but really what I've done here is just tried to think of some of the causes of cardiac arrest and then think about someone's admission after ITU once they're in that coronary care unit. what are we thinking and what are we needing to do, and how does that break down the differential diagnosis. And you can see that actually to cover all of, or at least most of these conditions, we need to be doing quite a lot of investigations, and we need to get to the point where we're doing some of these, so these challenge things are like provocation tests, right? So I said the ECG can disappear, so you need to do a provocation test to try and see if you can get that abnormal response. The two things that I never ever get from my cardiology colleagues, which why I'm very much appealing to everybody else to do this, right? The things that I never get are a family history, have people died young, do people black out, and I never get the rhythm recognition. You can see that I'm somewhat fixated on that. So those are actually really simple things, and those are things that can happen right at the beginning of the journey, and I struggle to get them sometimes from my cardiology colleagues. So this is a piece of research looking at the patients kind of at the end of that journey. So you've gone through all of those investigations in the coronary care unit, and you don't know the cause of someone's cardiac arrest. And what this group did then was do some genetic testing. So looking for genetic variants that are associated with those structural and electrical diseases that I talked to you about. And they were able to make a diagnosis in about 15 to 20% of people, okay? And these are well people who've survived a VF arrest, so maybe it doesn't make a huge difference to them. They've got a defibrillator in, they've recovered, but the people it does make a huge difference to are their family. So their first degree relatives will each have a 50% chance of sharing that variant which causes a potentially life-threatening condition. So this is something that we now do routinely in our inherited cardiac condition service to offer this type of genetic testing to patients who've survived a VT or VF arrest without a clear cause. So it's really thinking about these survivors and us as cardiologists thinking about the fact that, as you all know better than I do, not all of those patients are going to make it to that coronary care unit, sadly. So we need to also be in accident emergency departments, in intensive care units, so that we can get these patients and make sure that families are evaluated for these inherited conditions. And of course, sadly, some of these cardiac arrest patients will not have a worked resuscitation. They won't make it into a hospital, and those will be recorded as sudden deaths in the community. And for many of those, it will be the same VT or VF that caused that to happen. So we also need to extend this to families after a sudden cardiac death and offer that same level of evaluation. Obviously, we can't do the same degree of cardiac investigations, but we can do the genetic testing and we can evaluate relatives. And this is not to go through this in any detail, but just to outline that we have a protocol for this, which involves genetic testing post-mortem in the person who died. So a sample is taken by the pathologist at the post-mortem exam, and then we also do clinical screening in the first-degree relatives of the person that died to try to understand if that sudden death was caused by one of these inherited conditions. So about 18 months ago, we got some funding from the Scottish Government to pilot the role of a regional coordinator for these sudden death cases, partly because that algorithm that I just showed you is quite complicated and I was struggling to keep hold of it in a kind of usual outpatient clinic setting. So we're just through that pilot. So we started in the west of Scotland with Helena Davison, who's our clinical nurse specialist. Helena's amazing. If you haven't met her, I would highly recommend it. She comes from a nursing background, so she did cardiothoracic intensive care nursing, and she's been an absolute force of nature in pushing forward this pathway to try and improve the care that we deliver to families affected by a sudden death, but then also linking up with intensive cares and accident emergencies to try and increase the number of those cardiac arrest patients that we see. And because of her hard work and her success, we've just had funding from the BHF to upscale this nationally in Scotland. There is an equivalent there's an equivalent system being built also in England where the justice side of it, in Scotland we have the procurator fiscal system. In England there's a coroner system, so the kind of legal side of it is a little bit different, which is why there's two different studies. But we're now going to extend this clinical coordinator role nationally, and that's something that we want you guys all to know about. We're going to establish a direct care pathway for families that are affected by a sudden death, and also a national registry. And you've heard so many times about the importance of data, and we want to make sure that we are capturing this data in relation to sudden death so that we can try and produce something that's equivalent to the kind of cardiac arrest registries that you guys are all involved with. So this is what we're going to do. So rather than the previous disjointed system where after a sudden death, a letter would go to a relative who would be potentially unable to deal with what's in that letter. Maybe the letter goes in the drawer. Maybe they take the letter to the GP and the GP doesn't know what to do with it. So now we're going to train the fiscals officers to talk with bereaved relatives about this. So where a post-mortem has not identified a cause for that sudden death, then the fiscals officer would, with the family's permission, put them through to us so that we can have that seamless pathway. And we're also joining up with the Scottish Cardiac Audit Project to make sure that wherever death is registered as a sudden death, that we're collecting those data prospectively. The other thing that we want to do as part of this is try to develop some education and peer support for healthcare professionals that are involved really at any point in this. And many of you in the room will be, we've talked already about breaking bad news after a cardiac arrest call, and so this may resonate with some of you, and really we want to hear from all stakeholders about what is going to be useful. And we also want to try and develop bereavement and psychological support for affected individuals. These are some of the quotes just from focus groups that Helena did with family members after a sudden death, and we're not expecting that people are going to have really positive things to say about their experience in this regard, but you can see that there really are some points that we can build on, having GPs be educated, having earlier psychological support, and I think a lot of it will just be about the people on the ground, the guys who are having the contact early, and that might be some of you, being aware that there is a pathway, that there is a support network, and feeling empowered and confident to talk with families about that, or if not, at least knowing where to signpost families to. So just thinking about what we can all do for survivors of VTVF cardiac arrest where there may be an inherited cause, or families after sudden death. Document the rhythm in out-of-hospital arrest, please, please. There is no harm if you are in a clinical environment to take an EDTA sample and send it to the genetics lab for DNA extraction and storage. Nobody will ever start doing whole genome sequencing on that sample without anybody's knowledge, okay? It just is a way to make sure that we don't have someone dying in ITU from what might have been an inherited cardiac condition and us not being able to offer testing to that family when they come to us 6 months later. Contact us to discuss cases, please. I hope very soon we will have a national email address instead of one that's in the west of Scotland. And as I said, really just thinking about how we empower everybody to talk with families about this. And please tell us how we can build in your needs into what we're doing here. I just also wanted to signpost the Network for Inherited Cardiac Conditions Scotland. So we have a lot of useful, hopefully useful, tell us if it's useful, information on the website. So there are patient information leaflets related to sudden death. There are clinical pathways, and there are also clinical pathways that are designed for primary care and GPs. And again, we'd like to add content if there's content that's useful. So just to take home, inherited causes of VTVF are actually not rare enough, certainly not rare enough for us to ignore them. We know that relatives may be at risk, and rhythm identification and early communication are things that we can all help with and really, really key. Thank you all very much for listening.